if we go just a step further, you say to yourself, well, what's happened as a result of these trends? Well, the first thing that's happened, I don't expect you to understand all these data points. It's just the direction that matters. And what this data shows you, this is again our health plan commercial member cost sharing trends from 01 through 010. Back in the heyday of an HMO benefit design, you can see that for every dollar of spend in our plan, our member picked up 8 cents of that, right? You go 9 years later on a much higher base, and you can see it's moved to 18% in January. Now, it always comes down as people eat through their co-insurance and deductible. But this year, I don't have the 011 numbers yet because this is based on paid claims. We expect that number to get to 19–20%. So you get to a point where health insurance starts to look like life insurance because the sheer cost of using your insurance begins to outpace your ability to afford it. And this is what's happening in the middle class. The imperative on healthcare now is not to make it more available for the poorest in our community. That's an imperative. It's to make it affordable for middle class people. And you probably read the same article I did last month in Health Affairs. In 2009, healthcare costs 1 full percent of GDP, right? So we're now at over 2008. That's unprecedented. It never happened in the history of our country. So we're now at 17.6% of GDP. And for the first time ever, public education as a percent of GDP fell below 4%. Now, you talk to any health economist or any medical researcher in this country, and they will tell you, if we are all about the triple aim, it's not about spending any more money in healthcare. It's about taking 5 points of GDP out of healthcare and putting it into education, income security, housing, and food. If we do those things, we will get to the triple aim, not spend any more money on healthcare. And I think the community is beginning to get that at an intellectual level. It's sort of like, how do you operationalize that? Now, what's happened in our market as a result of these trends and the economy is, and by the way, what I wanted to show you in that last slide, which is very interesting on this one, look at what's happened to the PMPM at the top blue line. Even though price increases went up, people started using less healthcare with insurance because the recession hit. And it's like, do I pay my utility bill? I use my house every day, right? I don't think I can afford to use services anymore. And you've probably seen it too, if there are any health plan people here, a real dip in commercial utilization starting about 2 years ago. I think driven largely by the inability of people to use their insurance, right? I'm seeing shaking heads, right? Okay, so look what's happened in our market and the number of people that have been insured over the last couple of years. From the end of 07 to the third quarter of 010, when these data are now available, we've lost 15% of the commercial insurance market, the group market in our state. And people say, well, they just went to the individual market. No, they didn't. Individual market right here in red is dead flat during that same time. The only part of the market that's going up is Medicaid and Medicare, right? They're beginning to go up. In fact, starting Jan 1 of this year, 10,000 new Medicare eligibles every single day. So that's a wake-up call for us. Now, in that kind of environment, let me go back here because I don't have to use my laser. In that kind of market dynamics, why did the plans agree to come together and do a collaborative? The first reason is because the requests came very loudly and in a very unified way from key employers driven by chief executive officers who were fed up with the excuses that we all make in healthcare about cost shift and so forth. And my CEO was at that meeting. And he came back to me and said, "You're going to do this." And I said, "Well, I guess I am." I would say that you know, duh. These are our customers, duh. So it wasn't a tough push. There was, I think, real community commitment to doing something radical on plan design and having everybody do it together, so that purchasers could purchase it from their existing channel, not have to change plans. The chief medical officers that came together to work on this design, I'm going to get to it in a minute, were very supportive of this work. And it's very powerful to have senior medical advisors, first of all, agree on anything. And then secondly, look you in the face and say, this is how to run a healthcare plan, based on their clinical knowledge of doing the most good for the most people at the least amount of cost. That's the model. Most good, most people, least amount of cost. I think our interest in VBID is driven by this sort of sense that it's inherently right. That those of us that have been in the population health management business for a while understand that some healthcare is a much higher value than other healthcare, and why don't we just be honest about it and design it that way? And finally, I come back to the Oregon Health Plan legacy, this idea that we had already done this kind of ranking before, and why not do it another way for the commercial market? It made a lot of sense to us, right? But mostly, this was driven by chief executive officers of large employers coming together to look straight into the eyes of large health system leadership and say, your trends are killing us. You need to do something different. So in that environment, we designed 4 work groups led by a number of people at the Health Leadership Task Force. One of them I led around value-based design. We're going to talk about that in a minute. But the context of this work also produced 3 other groups. One driven toward best evidence-based practice design, a second around reimbursement and payment reform, and a third around reducing administrative costs. And I'll touch on each one briefly, but I'm going to focus on the first, obviously. So if you look at what we've accomplished so far, we have a value-based plan design that's in the market today, sponsored by 5 different plans. I'll show you that in a minute. We took on high-cost imaging, and all 5 plans came together to negotiate a contract with American Imaging Management, AIM. We now have prior auth in place for MR, CT, and PET scans, and they're all being done by the same way. And our goal is to try to learn from the utilization patterns and see what we can do in other areas. There's another one now that's starting to go around low back pain management. We have implemented, not unlike what you've done, a multi-payer, high-value medical home. We used the same consultant that did the Boeing work here, a fellow by the name of Pranav Kathari, who's a very bright guy, did a great job for us. And we now have 5 health plans that are working with 14 medical groups, along with some large purchasing groups, to and we have a high-value medical home initiative in place, started October of last year. It's designed to find the top, each health plan saw the top 10% of its cost, used a predictive modeling product, and we found our top 10% of users. And we put them into the care of these medical homes. The medical homes had to qualify. They were certified by Kathari's group. And we've come up with a payment mechanism where on top of fee-for-service reimbursement, we're paying $42 per member per month for these enrollees to purchase case management at the primary care site. It's a 2-year pilot. We hope there's going to be savings off the baseline, and if there are savings, they will be shared with the medical group. We're excited about it. I think it's got potential, but we won't have any meaningful data on this for at least another year. And finally, there's been a lot of effort to reduce administrative costs in the system by going to one health port, by getting a common credentialing approach, by doing a number of things to just take admin out of the system, right? So those are the 4 initiatives, and we've got about 200 people underway in this work. Let me move to the value-based design and tell you what we've done and how we did it. The value-based benefit goal was to reduce the financial barriers that some people face when trying to manage their chronic conditions. It was to support wellness and prevention and a culture of health. And thirdly, we purposefully went after a reduction in nationally recognized care that for a given population is driven by provider preference and supply, and not by medical evidence. And we used Wenberg and Fisher's work to guide us in that work. And finally, and most importantly, this design, the goal, the imperative from the employer community was find me 10% reduction and try to do something to moderate and bend trend. The 10% reduction had to be achieved. So the process was, we had a 25-person work group. I was the chair of that group, and it included some senior executives in health plans. We had all the chief medical officers of 5 major plans. We had some finance folks. We had some people from IT, because setting this stuff up is no easy task. And finally, we had 4 pretty aggressive employer benefit leaders who were they were kind of our conscience on whether or not this would fly, right? We had 10 meetings over 6 months. Each one was like 3 hours. They were long. We used the Providence Health Plan claims experience to do all of the analysis. We agreed to be the data cruncher on it, and that was important because you've got to have a reference point, right? We had very long and protracted dialogue about the cost sharing on Tier 3 benefits, which I'll show you in a minute. Brutally long, protracted dialogue. This work was facilitated by an ex-Kaiser executive who's a brilliant person, gets population health care, really kept us on task. If you've got to do this work, you have to have a really good facilitator who is on this every day in every way. And we did not really use market research on this. We've done some market research since we put this product in the market, and we've learned a few things. I'll talk about that. But we did not do any market research. We said, how are we going to find 10% in the premium without putting a $5,000 deductible in front of anything? Anybody can do that. Even I can do that, and I'm not an actuary.